All right, we're going to move on with three presentations returning to the aligning incentives theme and particularly thinking about how incentives and levers can be used to overcome some of the barriers we heard about yesterday in terms of implementation. And I'm going to start with a presentation from Dr. Mark Friedberg at RAND. He's a natural scientist at the RAND Corporation and a practicing general internist. His research focuses on the quality of care delivered by primary care practices, innovations in ambulatory practice, and improving methods for performance measurement in healthcare. His clinical work has included ambulatory primary care and hospital-based internal medicine. He's a clinical instructor in medicine at the Brigham and Women's Hospital and Harvard Medical School. And Mark and his colleagues at RAND have been working with us on a more formal evaluation of the demonstration program that you heard so much about yesterday, and it has been thinking about the challenges that those sites have faced and how we might overcome them. Mark.
Thank you, Michael. All right. So I just want to thank the foundations for inviting this presentation today, and to all of you for attending and listening. What I'm going to review now is a paper that we published in Health Affairs in the patient engagement theme issue earlier this year. But I'm also going to include some information that wasn't in that paper that's more focused on the measurement of the implementation of shared decision-making in primary care. I'd like to also acknowledge my co-authors at RAND and at the Foundation. So just to review, and I know this is going to be already known to those of you who were here yesterday, there was a demonstration of shared decision-making in primary care, and we focused on evaluating the first 18 months of this demonstration in a qualitative way, looking at the initial implementation of shared decision-making. We were in contact with 8 sites, collectively containing 34 primary care clinics. And just a little bit of background information about how they were inducted into the demonstration. They were selected for their prior quality improvement experience. Some, but not all, had prior decision aid implementation experience. The demonstration concluded last year, but started in 2009. It was sponsored by the Informed Medical Decisions Foundation and featured free decision aids to all of the participating practices, technical assistance from the foundation, and a learning collaborative that met on a regular basis with all of the demonstration sites. The objectives of our evaluation were twofold. The first is what we presented in Health Affairs, was to identify barriers and facilitators to implementing shared decision-making in primary care settings. The second was to develop options for near-term quantitative evaluation. And the kinds of measures I'm going to discuss could also be used in incentive programs to see whether implementation of shared decision-making is taking place. We conducted semi-structured interviews with 23 leaders and clinicians from all of the demonstration sites. We also interviewed 10 patients from one site who had each received a decision aid during the demonstration. Our interview protocol investigated facilitators and barriers to engaging clinicians and to integrating decision aids into key operational tasks of shared decision-making. We analyzed all of the interview responses inductively for recurrent themes. And I just want to spend a little time on this slide. These are the key steps of implementing shared decision-making based on decision aids that we identified, both from a review of the literature and from our interviews. So moving from left to right, first we have decision opportunity identification. So this is a provider or somebody in the practice, or the patient, him or herself, recognizing that there is an opportunity to use a decision aid and engage in shared decision-making. So first you have to know that there's a decision to be made. Secondly, match a decision aid to that opportunity. Then the decision aid needs to be prescribed and used. And then critical, that third step is the post-decision aid conversation. So this is where after the patient has used the decision aid, the patient and the provider then again meet. And when I say provider, this can be a physician or somebody else, and it may not even be the same person who prescribed the decision aid initially, to clarify medical information, make sure that the patient understands the material in the decision aid, also to elicit values and preferences from the patient in a continuing fashion, and also to make sure, hopefully, that the provider really does understand those values and preferences, and then to make a shared decision together. And this post-decision aid conversation doesn't have to be a one-off event. This can occur over time. Provisional decisions can be made and reconsidered, and various parties can also be involved in addition to the patient and the provider, including the family members. Finally, and very importantly, the fourth step, So healthcare is delivered, and hopefully this care is consistent with that final shared decision. We know from some of Dr. Frosch's work that that isn't always the case, even when there is a shared decision that is made. So here are some of the barriers we identified to making shared decisions in primary care. First, overworked physicians do not recognize decision opportunities and distribute decision aids reliably. I'm just going to read a few quotes to illustrate this point. Patients come in, and doctors are seeing them for 4 or 5 different problems. Remember, this is primary care. And then they have to remember if there is a decision aid for each particular decision. We hear physicians say, I seem to be the problem here. How do I get myself out of the loop so we can get the decision aids to the people who need to get them? And another site expressed this as follows. In the real world, I'm not sure we can expect the physicians to identify the patients. Another barrier was insufficient provider training in shared decision making. So recognizing decision opportunities and having post-decision aid conversations are skills that providers must learn. So physicians felt that they were already doing shared decision making before introducing decision aids. Or another site put it, you really have to pay attention to the clinicians in this equation. You can't just ask them to do something and assume they'll know what you mean. We underattended the training of our clinicians. And I think a key point here, not from this study, but from, I think, my own personal experience as a physician and probably the other physicians in the room here, that medical school doesn't really do a very good job, if any, of preparing medical graduates for shared decision making. The third, and I think very important barrier we identified was the inadequacy of clinical information systems. So some of these sites had electronic records, and some used paper. But particularly for the EHRs, and I think this is very important in the context of meaningful use, they were not able to track the full sequence of steps involved in shared decision making from my previous diagram. They were also not able to integrate with the decision aids. So some of these decision aids had questionnaires that would take the patient through a process of sort of self-discovery about what their preferences could be. And patients would spend time with these questionnaires, submit them, but they would not actually enter the clinical information stream. So as one site expressed it, all the information from the decision aid questionnaires is off the chart. There is documentation that a decision aid was given, but anything from the surveys is kept completely separate and therefore not available in that post-decision aid conversation unless the patient, him or herself, brought it. We identified some interesting solutions that the sites employed to overcome some of these barriers. So one solution that was key for 2 different kinds of decision aids was using automatic triggers for decision aid distribution. So this could trigger on a patient's age and gender for screening decision aids. So a good example here would be a decision aid around colorectal cancer screening or PSA screening. You can identify those who are likely to be facing a decision opportunity before they even come to the office based on their gender and their age, and distribute the decision aid before they come, and then at the visit have your post-decision aid conversation, assuming they use the decision aid. You can also trigger on specialist referrals, and this is particularly easy to do for surgical procedures. So you would refer to a surgeon. The doctor wouldn't have to remember that there's a decision aid, but in the referral protocol for the practice, the decision aid would be prescribed to the patient with the understanding that he or she would then use the decision aid prior to seeing the surgeon. If the post-decision aid conversation then happened in the specialty office, the feeling was that that was much more likely to actually occur because in a specialty visit there's a narrower range and greater focus on the surgical decision itself, and that may facilitate a more reliable performance of the post-decision aid conversation. Although it doesn't necessarily have to be the case that that conversation would happen in the specialty office. It could also come back to the primary care doctor if that was how the workflow was structured. Another strategy was to engage team members other than physicians. So an example was a decision coach to introduce the decision aid, and patients really pointed this out in the site where we did interview some of them. So here's an example. When you're with the doctor, you don't get a chance to ask a lot of questions. A nurse I had never met before came in and introduced me to the decision aid. She had a CD and a book about surgery, and of course I was interested in that. I want to spend a little time now on the measures for measuring the successfulness of implementing shared decision making. So based on our conceptual framework and also the barriers we heard at different steps of the shared decision-making process, we would like to suggest a process measure that captures all steps of shared decision-making. So an all or none measure may be appropriate here, with the idea that shared decision-making is a chain of events, and it's a little bit like operating room sterility. It's only as strong as its weakest link. So taking an average of all the steps may not really get a meaningful measure in the same way as a composite that considers all of them together. Just to illustrate the point, sites were generally able to measure the first two steps here, decision opportunity identification and decision aid use. Very hard for sites, and part of this had to do with their information systems, to measure these rate-limiting steps later on, or at least potentially the rate-limiting steps of the post-decision aid conversation and healthcare delivery. So an important part of constructing such a composite would be measuring these later steps in a reliable fashion. I think you've already heard about the measures of decision quality. So I'll just mention this is, essentially, in the end, was care consistent with the patient's values and preferences. And one other idea is to sort of back into what we think the world would look like in a situation of perfect shared decision-making. So I'll call these indirect measures of shared decision-making performance. So in theory, shared decision-making should produce variability that is driven entirely by patients, not providers, dovetailing on Dr. Wedenberg's work. So if each provider in an organization has, let's say, a PSA screening rate of 100% or 0%, and nobody's somewhere in the middle, it's at least unlikely that the organization has implemented shared decision-making successfully. And you can calculate the probability of the distribution that you're seeing and say, well, this organization is basically doing it or not. And that could be operationalized on administrative data, which is nice. So in terms of implications, achieving shared decision-making will require new operating systems for primary care practices. I think to summarize it in sort of some language from another industry, installing an app for shared decision-making on an operating system that isn't working very well may not be the optimal solution here. Instead, replacing the entire operating system for primary care might be really necessary to get reliable shared decision-making implemented. This means major investments in developing and improving educational, operational, and informatics systems are necessary. Payment reform, which is driving the development of these systems and their perpetuation, may also be necessary to the successful implementation of shared decision-making. There's also a key issue for policymakers, especially in the context of the Medicare ACO demonstrations. How high to set the bar for deciding what counts as engagement in shared decision-making? A lower bar would be to count the rate of decision aid distribution as an initial way of getting sites to adopt decision aids. But a higher and probably more meaningful bar, at least from the patient perspective, would be all or none process measures, including all steps of shared decision-making, or some of the other types of measures that we mentioned. Thank you very much.
And I'd like to thank Mark and his colleagues at RAND. Again, many of his suggestions from the first part of the evaluation that RAND did, you heard reflected in the efforts to overcome barriers in the stories we heard yesterday. And we're going to come back to that in the next two presentations as well. Bruce?
Yeah, Bruce Bagley from Transformat. I'm so glad when that slide came up with this quote from the physician, maybe I'm the problem. The whole theme kind of yesterday and to some degree today was how do we get physicians and other clinicians to change their behavior when in fact it's all about the systems of care, getting the team involved and using this. This is about standing orders. And about picking out the few things where we have high leverage decision aids and just getting to be part of the routine. I'd be the first one to admit there's a whole lot of places where we don't have good decision aids or that they may not be effective. But the ones we have, why aren't they part of the routine care? And I think that's the way we need to be selling this. This is the expectation of how primary care should be constructed and operated. The operating system analogy is great. Thank you very much.
Thank you for your comment, and I just want to point out that that's a very self-aware physician who would say something like that. And certainly someone who's sort of bought into the concept of shared decision-making and recognized that he or she, him or herself, is the rate-limiting step. One other corollary to that quote, though, and it's a little bit sad for me to, as a primary care physician, is it's not necessarily that physicians can't do this. It's that they're doing so many other things that may not require a physician, in my opinion, that may really be the problem here. And I don't necessarily think the solution is to excuse the physicians from participating in this, but instead to make sure that this is valued appropriately so they can prioritize it and spend time on it.
Just a comment about that. I think in the larger context, we have to start thinking about what is basically rules-based decision-making. Physicians probably shouldn't be involved very much except in designing the system that allows everyone else to follow rules-based decision-making. This is classic stuff that belongs in rules-based decision-making. It's not really the physician's daily work.
Thank you.
Go to Neil.
Hi, I'm Neil Corson from Maine Health, one of the demonstration sites. So I want to just talk a little bit about the points you made about physician education. So one thing that's going on in Maine, where we have now our own little medical school, I have a couple of colleagues who've been very creative about training both medical students and residents in shared decision-making using standardized patients. And what I really like about that approach is we always hear from physicians that we're already doing it. And I think it's really, we're never going to lecture to physicians to convince them that they're not, but by giving them an active way of having a conversation with feedback from somebody who has some sort of checklist, we can really demonstrate what they are and aren't doing. Mm-hmm. The problem with that approach with my system of 1,100 physicians is I don't think I can scale that. So what I'm thinking, and Michael and Richard, this is, I don't know, I know the foundation is working on education, but what I think we could use is some sort of interactive system that gives practicing physicians all over the country the opportunity to get a sense of what it's like to have a shared decision-making interaction that really gives them feedback on what they are and are not doing. And there may be people doing that. If so, I'd love to know about it. And if not, I think it's a great opportunity out there.
You may hear in a minute, but let's go to Marcus.
Actually, well, Richard was before me,
Do you want
actually.
to follow up on that point?
If I may, and add a second while I have the mic. Okay, so I want to thank Mark for the opportunity to work with you during this and the report and your presentation. The need for training became apparent, and it was quite obvious, really, that we should do that, and it should be accessible to practitioners, physicians, and other practitioners. So part of the challenge is clearing up the schedule to get people to participate in training. We'll hear at Group Health what a commitment senior leadership made in order to free up the time, take people off the line, so to speak, out of income generating to attend the training. But the tack that I think we're taking now is online, interactive, self-paced, case-based training. That is going to be a challenge, but there's some models for this, and that is to teach communication skills online by yourself is not necessarily the easiest thing, but I think we're getting some records of some indication of success, and we're going to embark on that. So I think we see that need, and we have to think about scalable solutions, and I expect within 6 months we'll be well down that path. In terms of the automation of the identification process that Mark has identified and recognized, we see that, and part of that relates to delegating authority to others, and sometimes physicians have trouble with that. But as we selected the sites to participate, we asked, can you give us some examples of standing orders that you have, so that we get a sense of where they are in their at least collective ego in terms of being able to do that. And we found that some were better than others at that, and that was part of our selection process. But it was only a generalization. But part of the challenge is sometimes it's easy to identify the person, but others you have to know whether in fact they're thinking about a decision and the clinical judgment issue, and it's not quite as clear-cut. So age-based, like we were talking about, or tying into referral processes, those are good ways to do it. Others are going to be a little bit less clear, I'm afraid. But thanks for the comments, and Neil, thank you for the setup on the training.
I think we'll take the last 4 questions here. Lots of great questions. Marcus.
Thank you. I'll tell you brief. Hi, Mark. I'm Marcus Tagetson. I'm from Blue Shield of California. Really appreciate your comments. Just briefly on the training, the Ottawa Hospital Research Institute has a good online tutorial that I think, obviously it doesn't do all the case-based experiential stuff that needs to be done, but it's a good place to start if you're looking for online training. Actually, my comment/question is really more about how the design of the decision aids that were used in this study to some extent influence the experience and some of the challenges. And in particular, there are folks like Lynn Elwood now with the option grid who are looking at simpler decision aids that can be used actually in the course of the conversation between provider and patient. I'm just curious as to how you think that would maybe influence adoption of decision aids. If we thought also not just about how to design the process with these decision aids, but what might a process look like and how might it be more facile if the decision aids were designed to be easier to use?
So I can only say what we heard in the demonstration, not being an expert on the design of decision aids, but we did hear that one of the attractive things for physicians about them was that it would impart a lot of information outside the setting of the office visit, which was already packed. And so implementing a decision aid, even simplified in the office that would take the physician's time, would potentially be problematic unless something else was removed from the plate.
George.
George Bowman, Gordon Betty Moore Foundation. Thanks for the presentation. I wonder if now is the time to say that there's been enough research, there's enough evidence, and the focus should be on implementation, and that the principles of implementation should be one in which we do not examine things that do not go to scale. We do not examine things that cannot be integrated into optimized workflow, and we do not look at things in isolation. So an example is that we have not yet heard, but it would be interesting to understand, for example, the effectiveness of decision aids relative to the stages of Judy Hibbert's patient activation measure. It could be interesting to understand how we can take to scale by learning from social networks, smartphones, other IT enhancements that have worked in every other industry other than healthcare currently. It would be interesting to understand how, as was pointed out before, decision aids and other activities can be in the context of behavioral economics such that the default mechanism is to have it integrated into workflow rather than imposed on a system that is already overloaded and frustrated.
Those all sound very interesting to me. Absolutely.
Let's see, LJ, and then we'll save the last comment.
So LJ Fagnan with the Oregon Rural Practice-Based Research Network. I'm sure some of those physician comments may have been ones that were in our practices trying to do this work, because it really is hard. It gets to the 18-hour problem of 7.6 hours to deliver all the preventive services that are due and 10.4 hours that are to deliver all the indicated chronic illness care. Physicians are overloaded, and so primary care takes place in a medical office, but healthcare decisions oftentimes take place out of the office visit. And I wonder, we're thinking about there need to be community-based interventions to provide these decision aids, whether it's at the Grange, or whether it's at the senior center, or some other structure to allow. We don't know what patients really want to know, and they sit around the coffee table and make decisions about what's going to happen oftentimes before they get to the doctor and have a conversation. And I wonder from a public health standpoint if we're shortchanging what we're doing with decision aids by limiting them to implementation in the medical office setting, and that they're community-based approaches that might be much more appropriate and take some of the load off the primary care physician shoulders.
I think that's a really interesting point. Absolutely.
Last comment.
Caitlin Smalley, I'm from the Medicare Payment Advisory Commission, and I had a question about scalability as well. I think we talked a lot yesterday about financial incentives and how that's important, but not the whole picture. And so I was wondering, you had mentioned payment reform as an essential piece, kind of moving this forward and bringing it to the rest of the country. I was wondering if you could talk a little bit more about what you envision that payment reform looking like.
So I guess in broad strokes, I would start with where the payment incentives are now for most people in primary care in a fee-for-service payment environment. So it's to see patients, essentially as quickly as possible, and to do as many things as are necessary to get up to the next coding level, and then move on to the next patient. So that's just sort of the unvarnished incentive. To do this, which is going to take some time, probably, whether it's the physician's time or somebody else's time, right now would not necessarily be something that would be good for the bottom line of a primary care practice. So the kinds of models that have been entertained and might be necessary to have in place would be medical home type payment systems where there's a per member per month fee that would cover this kind of time spent with patients. Also, shared savings models could also induce more adoption of this, especially if overuse is recognized, and then you want to focus on not just cutting back across both inappropriate and appropriate care, but to really focus in a way only on that care that's least likely to be appropriate.
Thank you. We've fallen a little bit behind, but the question of going to scale is a really important one, and we're going to move on to that with one of the broadest and deepest demonstrations I'm aware of integrating shared decision-making into day-to-day care. So David Arterburn is a general internist and health services researcher who holds positions as associate investigator at Group Health Research Institute and an associate professor with the University of Washington School of Medicine. He's one of our medical editors and has been at the heart of this really interesting implementation at Group Health. David.
Thank you, Michael. It's a pleasure to be here and to present a Group Health story on implementation around shared decision-making, implementing patient decision aids to increase patient engagement and to reduce costs of care. As Michael mentioned, I'm a medical editor and have received funding and salary support from the Informed Medical Decisions Foundation. What is Group Health? Group Health is a consumer-governed nonprofit healthcare system that integrates both care and coverage for over 600,000 Washington State residents. That's about 1 in 10 patients in Washington State. 2/3 of our members get care within our integrated care systems, or integrated group practice, from our salaried providers, and about 1/3 of our patients get care in a network of contracted providers. What I'm going to talk about today is really the culture change phenomenon, and I'm going to cover it very briefly. And if you would like a more in-depth review of what happened at Group Health and how we actually accomplished what we did, Ben Moulton has an excellent article in Health Affairs that you have in your packet, page 294, where he covers the details of the leadership change that was required. But what was Group Health's pathway to large-scale implementation? What infrastructure elements did we put in place to help support shared decision-making? What did we do to create a culture of expectation around shared decision-making and help to begin to build competencies among providers to provide shared decision-making at point of care? What outcomes have we observed, and what next steps are we taking to optimize shared decision-making? So first, what was our pathway? Really, there were two key things that happened to help motivate shared decision-making in Group Health in Washington State. But at Group Health, it was, the leadership really understood this problem of unwarranted variation in the Dartmouth Atlas, but they didn't really understand it for themselves until they began to look at their own data. And this is just a graph that shows changes in knee replacement rates in different regions within Group Health in their own data compared to the state averages or state rates for knee replacement. And what we found is that over time, we had very large changes in knee replacement rates. Actually, I'll have to use the pointer, not the, sorry. Having the same problem Jack's have with the pointer. So we had very large changes in knee replacement rates in a couple of our regions that were jumping up above the state average in terms of knee replacement, whereas other regions within group health were staying below the state average. And it was this level of data at group health, unwarranted variation, which motivated leadership to say, we have some problem here that's not just a national problem, but a local institutional problem that we need to try to address. And the other key piece of that actually led to change into shared decision-making in Washington State was that in 2007, as a result of some of the work that Jack did coming out to Washington State, as well as Ben Moulton and Jamie King, came out to talk with legislators there, we passed new legislation which recognized shared decision-making and the use of patient decision aids as the highest standard of informed consent in Washington State. It also mandated but didn't fund that the healthcare authority would implement shared decision-making in demonstration projects throughout the state. As an update, and you'll hear more about this later, in 2012, Washington State has now authorized the healthcare authority to certify patient decision aids that would allow them to meet the legal definition of the highest standard of informed consent. So those were the two key elements that sort of set the stage at group health for shared decision-making, and they motivated leadership to take action towards implementation, having protection under the law, the potential for liability protection there, and understanding we had unwarranted variation within our own system. So what infrastructure elements did we put in place to help support shared decision-making? We began with an ambitious plan for system-wide implementation in 12 preference-sensitive areas that were related to elective surgical procedures using the Foundation and Health Dialogue's video-based decision aids. Supported by Health Dialogue and the Informed Medical Decisions Foundation, we chose these 12 areas that are presented here. They covered 6 different specialty service lines. And so one of the advantages of working across so many different specialties is that we didn't have providers raising their hands saying, you're really kind of picking on us here with this new quality improvement initiative. It was an across-the-board initiative that group health was undertaking, and so it had a lot more institutional support in that way and a lot less pushback from providers because they felt like this was really an across-the-board initiative. But it really took top-down leadership saying, this is work that we need to do. We also implemented electronic ordering of patient decision aids so that a provider could go into our Epic electronic-based medical record, type in SDM into the order field. They could also type in video or DVD, and it could come up as well. But SDM, and it would pull up the order field, and you could see the whole list here of patient decision aids that would come up for them that they could order. And once they clicked the order entry, they could order the abnormal uterine bleeding decision aid, and it would be mailed to the patient's home by our resource line so they could watch it with their family in advance of seeing their provider or having the next conversation with their provider. The second thing we did is made them available online through Epic's Secure Patient Portal. Patients could log in and view them. Also, providers could secure message their patient, so they could send a message through the electronic medical record to the patient. It would have a link embedded in that message where they could then go online and watch the video online. And you can see here the videos, they're relatively long in length, 54 minutes, 55 minutes, 30 minutes here. But patients didn't push back on the length of the decision aids. These are treatment decisions that they're facing in real time, and they have a real appetite for high-quality information. Many of them are already going to the web to try to get information, but the length of the video was not a barrier. This just touches on that we implemented smart phrases and other tools in Epic to help providers document shared decision-making conversations so they can have information put in the medical record which says that they had before decision aid viewing, they talked to the patient and recommended that they watch the decision aid, and that we would have an appointment to finalize the treatment plan, or after decision aid viewing that they had engaged in a conversation, discussed the content, clarified preferences, and answered the patient's questions. This is a piece of work that's still very much ongoing in terms of getting providers to use these tools on a regular basis, but we did implement them and make them available for providers. In order to get decision aids used, what we really needed were staff on the ground, and Group Health had project managers who were staffed to work with practices in the specialty settings. They were hired to carry out this work. We had 3 full FTEs in the first year of project management, working with service line leaders, meeting with frontline service line providers, setting go-live dates around the flow plans, and then continuing with ongoing quality improvement, process improvement initiatives with monthly ongoing updates about decision aid delivery. What did we do to help create a culture within Group Health, to a culture of expectation around shared decision making and build competencies with providers? You know, we've already heard many providers say, I already do shared decision making, but our leadership felt, and this is a slide directly from one of our leaders' talks, that of course this is what it looks like. Of course it's totally up to you, but if it was up to me, I would choose surgery. And that's really what we felt was going on. And so it took leadership change to actually push the spectrum. And another slide from one of our senior leaders says that, you know, the cultural spectrum around shared decision-making could be, you know, this is nice to do if you have the time and inclination, or all the way over to no patient should undergo a preference-sensitive procedure without documented evidence that they got all the information they needed and had a conversation with their provider in which their preferences were documented before they made a decision. And our Group Health leadership wanted to push all our providers right over to that area of the cultural spectrum. And the key pieces that they implemented were they required every provider to watch the videos that were related to their health conditions that they were treating. They had pulled providers, these are specialty surgeons, surgical providers, out of their clinics and out of their practice days to attend a half-day CME and got 90% compliance within our specialty provider and surgical training specialists to come into a CME that was co-hosted with the Informed Medical Decisions Foundation around shared decision making. And then we gave them lots of feedback. We had monthly feedback to leadership and to providers on the front lines on the volumes of decision aids they'd ordered, the number of surgical procedures and the total costs of procedures that had been performed, the number and percent of surgical patients in each specialty who had had a surgery without having a decision aid viewed. And then we gave them information about patient satisfaction, and that turned out to be a really key component of how we helped promote culture change within Group Health. The leadership expected a number of key outcomes. They expected better patient knowledge, improved satisfaction. They hoped that over time, as Jack was talking about, we could actually establish the true rate of demand for these procedures and begin to reduce the unwarranted variation that we'd seen in a number of different areas. But really, this was about patient safety for our senior leadership. They recognized that if it was not an informed patient making the decision about elective surgery, that it could be the wrong patient getting elective surgery. So now moving on to what our outcomes been. Since beginning in January 2009, over a 4-year period, we delivered more than 31,000 patient decision aids in these 12 preference-sensitive health conditions. Over time, with the number of missed opportunities, that is, patients who are going for elective surgery who did not have a chance to view a decision aid, has declined dramatically, down from, you can see at the very beginning, we had 100% of patients going to surgery who had not viewed a decision aid in January 2009. Through August 2012 and now, including today, we're down to around 30% of patients. So we've made significant progress, but we're not all the way down to what our benchmark is, our dotted line. We expect that 10 to 15% of patients may have other health conditions that would be indications or some complications or issues that might make this not a preference-sensitive condition. Not every one of the patients that are going for these procedures really has a preference-sensitive condition. And so we're setting a benchmark low, but not all the way low, and we're not all the way there. But you can still see we're having 50 to 60 patients a month that are still going to the OR without having had a shared decision-making opportunity informed by a patient decision aid. So we still have room for improvement. but we've had a substantial impact on patients' satisfaction. The first 2,000 patients that we surveyed in the first year of implementation reported that 96% of them said that these decision aids were very good, or excellent in helping them understand their treatment choices. And that 95% of those patients said that they were very good, excellent, or good in helping them be prepared to have a conversation with their provider. When we fed this information back to the individual providers, this helped them to understand that this is value added to their patients. And that helped to motivate for them that this is something that I should want to do. My patients would like to have it. In fact, many of the patients were writing in, do you have decision aids in other areas that are relevant to my own health care? And as was mentioned earlier, we recently published some of our initial evaluation in the orthopedic service line, where we looked at the impact of introducing patient decision aids and this culture change phenomenon that I talked about on rates of knee replacement and hip replacement. And we saw 26% lower rates of knee replacement after the first 18 months of implementation, and 38% lower knee replacement, 26% lower hip replacement after the first 18 months of implementation, which led to 12 to 21% lower healthcare costs, total healthcare costs for those patient populations. And so the conclusion from our senior leadership was that we were both impacting patients' quality of care by having better informed patients based on the literature, and also having an impact on our bottom line that was favorable. This is the sort of slide that demonstrates the magnitude of the effect within the orthopedic population, comparing our control group, which was a pre-shared decision-making implementation. This is their total cost of care in 6 months after seeing an orthopedic provider for hip and knee osteoarthritis. And then you could see what the in the shared decision-making, after shared decision-making implementation, we were saving around $2,000 to $3,000 in the 6-month period per patient after implementing patient decision aids in these cohorts. So what are our next steps as we move forward at Group Health, given what we've learned around shared decision making? And actually, before I go on, I wanted to just put a footnote about some other data that's in process that we're hoping to have published within the next year around urology decision making. And patients with treated BPH also chose elective surgery less often. Patients with prostate cancer, early-stage prostate cancer, were much more likely to choose no treatment after implementing patient decision aids. And patients who were facing an elective hysterectomy decision, there was a significant trend. There was a trend. It was not statistically significant, but it was a trend towards lower rates of hysterectomy. And all those data are in process. So Group Health is now moving forward with new decision aids being added. We've already implemented acute low back pain, chronic low back pain, and weight loss surgery decision aids. We're also now implementing decision aids around end-of-life care, end-stage renal disease, and we're anticipating the introduction of the Foundation's maternity suite later this year. There's a decision aid around meniscal tear and also early-stage knee osteoarthritis, which we're implementing with orthopedics as well. And we're beginning to move upstream away from our specialty care systems and more towards primary care. In 4 primary care clinics this year, we began an implementation process, and we're going system-wide across 32 clinics by the end of the year. The idea here is that any patient who's diagnosed with a health condition would have their primary care provider let them know that they have a decision aid, ask them if they want to watch it online or have it ordered and mailed to their home, and ask them and have them have a follow-up conversation prior to referral. And we have implemented this in areas where we have a lot of external referral from our system, where we're referring outside to specialists that are not within the group practice. We're asking patients to have a follow-up conversation with the provider either by email or by phone or in person. We're also creating Epic-based tools, more tools to help support shared decision-making. This is a smart set order area where the providers can easily document progress notes, can send the patient educational materials, can refer them at the same time as ordering a patient decision aid, can implement the right kind of documentation around shared decision making at the same time, all with one click of a button within Epic. And then finally, we're implementing the feed-forward questionnaires, which are the decision quality instruments that have been developed by the Foundation. We're implementing those in our MyChart, the Epic patient portal, so patients can complete these online, and they will actually go into the electronic medical record so that the provider can pull them up at the point of care, and they can actually review the patient's knowledge, the patient's values and treatment decisions at the point of care, and that's going to be live this year as well for all the areas related to elective surgical procedures that the Foundation has developed decision quality instruments for. So that's going to, we think, have an important impact on the way in which providers engage patients at the point of care. And that's all I have. I have actually one conclusion slide, or two conclusion slides. One is large-scale implementation is feasible, and the second is that we really believe at Group Health that shared decision-making helps to achieve the triple aim of healthcare, which is higher satisfaction, lower costs, and improved patient quality. Many, many acknowledgments for our collaborators at Group Health.
I think what I'm going to suggest is if we could hear the next presentation. David, maybe I'll have you join me up here, and then we'll take questions for both presenters to move ourselves along a little bit. So this is another story of large-scale implementation from our colleagues at Health Dialogue. David Viroff serves as Health Dialogue's Senior Vice President for Innovation, responsible for developing new programmatic and analytic capabilities and for research activities. And what I'll do is let him go ahead and tell you about another approach to implementing improved care for people with preference-sensitive conditions.
Great. Thank you, Michael. And thanks to everybody here for attending and this great program. Thanks to both the foundations as well. I'm going to start just by telling you a little bit about Health Dialogue, just so you know where we're coming from. We're a total population health company, and our DNA and our fabric is about shared decision making. Our mission is to empower people throughout their lives to make the health and healthcare decisions that are right for them. So you can see this is really important to us. And just so you've heard this several times, but along with our terrific partners at the Informed Medical Decisions Foundation, we develop many of the decision aids that have been presented here. Just also, we have Wenberg DNA in our system as well. Jack was a sort of founding advisor for Health Dialogue and was also very involved in helping the strategy and implementation of our programs over the years. And his son, David Wenberg, was a senior executive at Health Dialogue for many years and was instrumental to the research I'm going to describe here and actually helped push us hard on research the entire time he was at Health Dialogue. I'm going to be talking about a big study that we did with 3 regional health plans and 7 employer groups. And this program is essentially a remote model for supporting people in shared decision making. I'll talk to you about the details here. Just sort of the background on this, has been well demonstrated that there are important deficits in decisions and participation about decisions from patients, and that it's also been fairly well documented that shared decision making improves care and care experiences. But what was lacking and continues to be lacking in some respects is what's the impact on total cost of shared decision making. So we decided that we wanted to take a big swing at this, and we conducted a large randomized trial comparing 2 levels of telephonic support for people with conditions that involve multiple treatment options. So this analysis actually started with a previously published study in the New England Journal, which was really a huge study of population care management involving 175,000 approximately individuals, comparing two different levels of care support, a base level and a very extended level where we were pushing our interventions to a much broader group of people. And that study demonstrated an overall cost impact of this expanded service of 3.6% on costs and a total population admission reduction of 10%. So this is a big effect. What we did in that study was to do a structured randomized, stratified randomized sampling approach to make sure that we had good balance in the two populations. And I'll show you some of the results of that. The implementation involved us doing rigorous analytics to try to figure out the right people to intervene with. Essentially what we're doing was looking for people who were likely to need future healthcare services, and also focus some specifically on the question of preference-sensitive care. We took that list and then rank ordered people and then decided who we were going to intervene upon. And the intervention itself was a series of efforts to try to get people to engage with health coaches. And the health coaches were actively trained in shared decision-making and actively involved in supporting people in a range of their healthcare needs. We'll talk a bit more about that difference right now. So the enhanced program versus the usual support. The usual support program was focused primarily on people with chronic conditions and some targeting to people with preference-sensitive conditions. The enhanced program took this and expanded it significantly within those two populations and also expanded to people who had other risks. The essential difference here was about 3 times as much outreach happened in the total population. What we did in the analysis that I'm going to describe here is focus specifically on the group that had a set of conditions that indicated they might have need for shared decision making. And that group included about 60,000 people across both the treatment and intervention group. So just to describe the baseline characteristics here, these two populations were very similar at baseline. This is prior to any interventions. We had about 30,000 in each group, and the costs and resource utilizations were very similar. We have a really detailed table on this that shows that everything was very similar. All the demographics were very similar, and all the prior utilization of our services were very similar. So we can only assume that at baseline these groups were identical. And what we did was significantly more intervention in the two groups. So the darker shaded group here on this slide is the group that got usual care, and the lighter shaded group is the enhanced group. And across the board, for all conditions, we had about 3 times as much intervention in the enhanced group as in the usual group. And these are just 2 of the measures. This is health coach contacts. The scale here is per 1,000 individuals in the study. And you can see that the health coach contacts across the board were about 3 times higher for all these different conditions. And also, since we had our shared decision-making videos, we were actively promoting those. Health coaches were engaging with people, talking about their needs and concerns, and then when necessary, sending them shared decision-making videos. And you can see that the utilization of those shared decision-making videos was obviously quite a bit higher in the intervention group. So what happened here? Well, we saw a dramatic impact on total costs, on utilization across the board. In particular, the total cost impact was 5.3% in this group. resulting in about $23 PMPM difference in costs between these two groups. This is for a program that essentially costs about $5 PMPM additional to execute. Now, clearly, this is a go big or go home approach. That's a lot of resources dedicated to this program. But in this case, we were trying to demonstrate that putting a lot of resources toward this effort would actually result in a lot of impact, and it did. You can see across the board the other costs were impacted, particularly inpatient costs, 12% impact on inpatient costs, driven by a utilization difference. It wasn't a cost of price difference, obviously. The inpatient admission rates went down 12%, 12.5%, sort of directly correlated with the cost difference. And we saw surgery rates go down about 10%. Not much impact on imaging studies, and we have spent a lot of time thinking about that and wondering why that was the case. And I think it's probably because our identification criteria were very focused on the surgical decision, so we were focused on getting people right at that point that they're making the decision, and may have been too late for the imaging question. So the implications on this are that actually shared decision-making may have power well beyond the question of surgical decisions. In this group, there's no way that we could have achieved that kind of cost savings just through reducing surgery rates. So this intervention, which was a whole person support program for people with these conditions, but it was with a lot of training and focus on shared decision making, resulted in broad total cost impact. And then secondly, this is an entirely remote program directed by health plans. In this program, there was no direct engagement from physicians. So this actually serves as a potential model when physician adoption is slow to come, and can actually result in, over time, in a fully integrated program that sort of wraps around physician adoption. We're firmly in the camp of believing that physician adoption and engagement is going to enhance these results, but we also believe there's ways to get going without the adoption.
So we saved quite a bit of time for discussion in our last section, and I think we'll borrow a little bit of time there to take a few questions for David A. and David V. and shorten the break a little bit. Bruce.
This is great. I'm glad we have David A. and David V. up here, because my challenge is actually to everyone in the room, and you guys are great representatives to help talk about it. If 75% of every person in this country has access to the Internet, one half of them have gone on the Internet to inquire about a health-related issue, and of those searches, 60% are people looking for condition-specific stuff for themselves, their family, or their friends. That's a huge opportunity for us. David A., when you mentioned that you have all these decision aids on the secure website, why aren't they available to link from anywhere? So why don't we take those decision aids and do search engine optimization to make sure that when I type in hip pain on Google, it's number 1 or number 2 that comes up? Why can't we do that? And I would challenge this entire room to start to think about it. We have people here from foundations, we have people here from federal agencies, we have people here from health plans and provider groups. How can we collectively make that happen? So when I type in hip surgery, the first thing that comes up on Google is a decision aid. Help me understand why we can't do that.
Take a first stab at it. I think one of the key issues there is while there's an upfront production cost, there's an ongoing maintenance cost to these decision aids. High quality decision aids require a significant capital investment to produce, and so the question is, making them free is a challenge. So I think we do need models of delivery that are lower cost, that we can get them in patients' hands. But having them freely available on the web, I think, it would be wonderful to have a source of support, financial support that was stable, that could allow that to happen. But I'm not sure that we've stumbled yet upon the model, and others here could probably speak better than I of how you do that. But I think if you want really high quality tools in patients' hands, I think it has to cost something.
Next question.
Yes, well, it's fascinating to see these two presentations, great contrast between physician engagement and no engagement. But for David A., I'm wondering, for your contracted physicians, I'm assuming they're probably not on Epic. How did you loop them into the system?
So that's an ongoing work in progress. And one of the key things there is that we went direct to consumer, much the way Health Dialogue has been doing their work, where we were identifying patients at the time of referral and sending them notifications, and then doing actually telephone outreach as well. We've done pilots of that to engage patients and let them know they have decision aids that are available. But we're now working with larger multi-specialty group practices, and in particular right now we're having a good pilot with an orthopedics network practice that is fully engaged in this, and they want to be trained in shared decision making, and they want to be using our patient decision aids. And so these opportunities do exist in the network, but in the smaller practices where there's lots of other competing demands, it may be more challenging.
So you are looking at maybe rolling this out to contracted PCPs as well?
To network providers as well. We're looking at that idea.
Next question.
Quick question for David B. You had mentioned in your intro to your study that there was an impact on both admissions and readmissions, and then you said it was 10% decrease on admission rates. What was the impact on readmission rates?
That's a great question, and I don't know the answer to that. I'm sorry.
It just seems like with the focus right now at the national level on decreasing readmission rates, that could be really powerful data.
Take the last three comments, starting with Dan.
Daniel Wilson from the ABIM Foundation. I think language is really important to this cultural change and engagement of physicians, and as soon as we say cost, we will lose physicians. If we say quality, patient safety, and I loved Jack's medical necessity equals appropriateness plus preferences. I think that is a game changer about how to think about the language. But talking about cost, and we've done many focus groups, you lose them in a nanosecond. And I think even the title of your article, I wish could have said, improve quality and safety, forget cost. We know cost will follow. Thank you.
Marcus?
We had two wonderful presentations. Thanks so much. My question is for David Arterburn. So, David, when I read your article, I was thinking, I had the voice of my actuaries was in my head, and they're always telling me that all the stuff that I do in terms of care management actually isn't having any effect because it's all secular trend. So I looked at your results and I thought, well, gosh, this study unfortunately sort of coincided with the great economic downturn of the late 2008, 2010, 11 period. I'm hoping that you have done some kind of analyses, either like subset analysis in your data, looking at like dose response kind of curves, or whatever, or some other kind of analysis that would tell us that in fact this is how much of this effect is related to the intervention and how much is related, hopefully not very much, to the economic downturn and the reduction in utilization that we've seen pretty much across the board right during that time.
Great. Yes, we're lucky in Washington State to have an inpatient hospitalization database that is statewide mandated. All hospitalizations go in there. We analyzed that database over the same time frame in the same counties in which group health has a dominant presence, in which we were in our integrated group practice. So comparing our changes in rates of surgery over that period of time of 2007 to 2011, and comparing that to what was going on in the same counties in the state, the rate of knee and hip replacement was going up or stable in the state during that period of time for the same counties. So those data do include some group health admissions. You can't extract certain providers, but overall, I think it suggested that the economy was not having a major effect on knee and hip replacement rates in those regions of Washington State during the period of time where we were seeing the 26 to 38% reductions in rates of knee and hip.
So that's very impressive. So one last question. Are you seeing a reduction in variation within your system, and are the rates converging, or the high rates are falling faster than the low rates?
So we have some persistent variation. It hasn't removed completely, and we haven't done the detailed analysis that we need to really be able to say has it significantly reduced. But we still see evidence of variation. As it's been discussed already, it's hard to change provider practices, and it's certain regions of group health that have higher rates than others, and changing the provider, the overall practice style, changing the way in which all those patients' care is delivered. I think it's going to take time. We see this as a long-term investment towards culture change. We're investing in the new providers, especially that are coming on board. We have a training process for them in which we're going to be incorporating shared decision-making. So I think over time, we may begin to see more convergence around the variation problem than we have currently. I think initially, overall, we saw a reduction across the board, but not necessarily a real tightening up of the variation problem.
Thank you.
Charlie, last question.
For David A. I think your plan to move the decision aid distribution for the preference-sensitive decisions upstream to primary care stands a good chance of having even greater impact on utilization. And we've tried to do that at Dartmouth with what we've called the Provisional Referral Project. And the struggle has been coming up with a way to implement that relies on something other than primary care physician initiative. We've tried some queuing and reminder systems without great success. I was wondering what your plan was to try to minimize missed opportunities.
Right. At this point, it relies quite heavily on provider engagement. In our pilot, we haven't yet debriefed with all the providers yet around their experience in the first 5 months of the year doing this work, but that debriefing is ongoing. Recent conversations with leadership say they think it's actually a little early to tell, but we're trying to gather more information from those providers' experience to see what's going on. But my hunch is that it's going to be the pre-visit work. That's what really worked for us in specialty. So having flow staff and other staff in the medical clinics identifying potentially eligible patients for these patient decision aids in advance of the visit, and trying to deliver decision aids prior to the visit with the primary care provider may be the best route to ensure that the provider burden is reduced, that they don't have to remember to do this. It becomes part of the standard work for the care team, and it ensures that you tee up an appropriate conversation with primary care at a time when it's face-to-face with the patient.
Thanks to both Davids.